Okay, I guess we're live. Hi, this is Elliot Fishman, and welcome to our weekly Facebook Live. And usually we do it 12 o'clock, but I need to catch a plane, so I need to be out of here before 12. And I'll be back tomorrow, but nevertheless, want to make sure we didn't miss setting. Those of you, if you didn't notice it, on yesterday's Facebook feed, we did a Facebook Live with Tina Wells, who's head and founder of Buzz Marketing, gave a great talk last night at Hopkins talking about some of the cultural changes going on, looking at Gen Z and millennials, looking at all different generations and how things and what things are trending. And of course, one of the big trends is artificial intelligence. One of the big trends is how people look at healthcare. So a number of things that are very interesting, but go back and listen to the talk yesterday. I did interview her, and there's some really good pearls in there. And this talk is going to be on oral contrast. So I will give people the opportunity to ask questions. Hopefully I'll be able to see the questions when they come up. I went to the Society of Abdominal Radiology very, very briefly. We're a little tight staff, so I flew up, believe it or not, on Monday morning. Got to Phoenix. The meeting was in Scottsdale about 10:10. The plane was on time. I watched 9 episodes of Larry David, the whole season, and I cropped 1,423 slides. Not bad. And then I went, twiddled around for a few minutes, was part of a panel on oral contrast, and then I turned around and I was back at my house by 11 o'clock. That was pretty good. It wasn't very good movies. I didn't have a really good system on the flight home, so I think I snoozed the whole way and watched a little bit of Coco, which won the Academy Award from Pixar. Anyway, with that said, what was the meeting about? So this one session I was at for other participants, and it was looking at the role of oral contrast. And obviously this was sponsored by GE, so of course a lot of interest was in the use of positive contrast, but the session was really only sponsored by GE. People who went, there was about 150 people, so a lot of people got a free lunch. It was an okay lunch, but for free. I didn't have any. I did take a water, so that's my disclaimer. I had a water. Only drank about half, but did take a free water. But they were speaking about oral contrast. First they looked at oncology, then they looked at the ER, then they looked at general. And there was 2 speakers. Beignet was one of the speakers from UCSF, and the team from Mass General also spoke. And you know, the question was, what do you do with oncology patients? We'll start with that first. Dr. Sassani from Mass General, I should have said that. But they both said that in the past, they went to basically no oral contrast in oncology patients. Obviously, they used IV, but they noticed independently, which we would surely agree with, is they were missing a lot of lesions. And Beignet made to the point that at tumor board, they were missing like 3 cases a week of masses, the small bowel, mesentery, and the like. And I would admit some of them you could see, perhaps if you used more coronals in 3D, but the point was you were missing things that were easy to see with positive contrast material. There's an article I remember Perry Pickard wrote a couple of years ago, which made the same point, that you were missing things you shouldn't miss because you were just thought maybe it was more convenient not to give oral contrast material. So both of them said that now in routine oncology patients, they are giving positive oral contrast material with IV contrast. Now, obviously, you're doing dual-phase pancreas or dual-phase liver or kidney or any CTA, you're not giving positive contrast. But for the routine colon cancers, lymphomas, and you name the tumor, they are giving positive contrast material. So that kind of was a change. They polled the audience. I'd say about 75% of the audience used oral contrast in that regard. We asked how many people use barium. I think like 1 person raised their hand. Everyone else used Omnipaque, oral Omnipaque. So, which is not surprising. Oral Omnipaque is cheaper, tastes better, basically has no taste. Patient compliance is high. Patients drink it 1, 2, 3. And so speed of process is high. They did mention that they try to wait an hour, but usually they wait about a half an hour. And I think that's our experience too. I think CT is more like Domino's Pizza now, 30 minutes, so your next one's free. So we get everything done by 30 minutes. But even in that case, the stomach, proximal bowel, is well opacified. I think if you're really thinking about getting things into the colon, you're going to be waiting 90 minutes. And realistically, the 90-minute days are no longer here. No one is waiting 90 minutes for anything. They then spoke about the ER. And again, this whole issue, when they raised, they asked the question, how many people use oral contrast in the ER? There was a paucity of people, maybe 10, 15%, which was kind of interesting. And I think I made the point that I thought that was kind of crazy because, you know, with ER, just pick the stomach for a second. If you look at your own reports, if you're not giving an oral contrast, even giving water, all of your reports in the stomach say something like stomach not distended, cannot be evaluated. Stomach not distended, can't rule out pathology, advise clinical correlation. Stomach not distended, cannot evaluate, advise endoscopy if clinically warranted based on a clinical situation that may clinically warrant a clinical situation that may be warranted to do endoscopy. Okay. So the reality is the stomach alone, you have acute abdomen, abdominal pain, gastric ulcers, gastritis, theoretically gastric cancer, perforation. You're going to miss a lot of those things if you're not giving distension. And just think about it. What are you saying in your reports? It's like sheer madness because you're not really saying anything. You're telling the clinician that I'm not evaluating a great part of the study. And all you have to do is, even if you gave the patient oral contrast 5 minutes or 10 minutes before the study, the stomach will be well distended, so would the proximal small bowel. And there really is no downside. It's not slowing you down. Even if you gave the contrast when the patient was standing up, getting on the table from the wheelchair, the contrast would be distending the stomach, and you would avoid the problem. So there really is no excuse not to give oral contrast material. This idea that the ER docs don't want it because it slows the process down, it's a silliness thing. Now, I will say that one problem people mentioned perhaps is that if you're in a hospital waiting to get oral contrast from the pharmacy, that's a pain in the ass. I agree. And they wanted to do that at Hopkins a number of years ago. We fought it. And it doesn't happen. But I know that if you're getting something from the pharmacy, it's 2 hours. And so that's not going to work. I will admit that if you have that problem, try to work on the problem. But if you can't solve that problem, give the patients water. Water is still a good contrast agent. It's good distension. It avoids missing those obvious gastric lesions that you feel really dumb and you feel bad about. So there was a lot of discussion about that people need to rethink the process. We basically have created a problem that didn't exist, right? We always gave oral contrast. You look at CT 30 years ago, you had pre-spiral CT, pre-helical CT. You're taking a minute a slice, you're still giving oral contrast. So the fact we've evolved, it's kind of like we evolved. Now we're back in the dinosaur with the brontosauruses and the stegosauruses and whatever those sauruses are. But it seems kind of dumb going backwards. And so I think there was a pretty good feel that oral contrast really is making a comeback because it kind of got tapered for no really good reason. And in fact, when you start looking, the reasons are very bad. Now, what about reactions to contrast? If you give oral Omni, theoretically as iodine, very minimal. There's about 5 or 6 reported cases of patients having allergies in like 20 billion doses. So it's just not going to be really a problem. So that's not an issue. Again, waiting longer is better than waiting shorter, but we're all going to agree that you really can't wait an hour anymore. Ideally, if you're very efficient, and what we do in our situation is, as the patient's getting an IV, we give them the oral contrast. Our techs are very proactive. So by the time the patient gets the IV, they sign the consent forms, they do everything, and then get in the scanner, the contrast is far enough down. So it really is satisfactory. Again, the ideal old days, forget that. Now, some people did mention they have patients come in the day before, they pick up oral contrast, the oral contrast is given to the patient, they drink it at home. I guess that would be great. We never did that at Hopkins. It's impossible for us. Just our logistics, patients coming from far away, having patients come twice. Some people I know in the past have had their referring docs have the contrast in the office, but referring docs don't want to be doing that. They have enough problem with space and doing their own job, let alone that perception that doing our job. So that really is not really a good way of doing things. So I think it was pretty good consensus, I think, from the audience as well as from the faculty involved, that oral contrast is a very important thing to do. And again, we need to rethink it. I think one thing that needs to be done, and I've mentioned this before, is particularly in an era where we have Pyxis machines. Those are the machines where do the billing and store the material or the drugs, even aspirin. As you know, you can't get free aspirin anymore at the hospital. You need to have these Pyxis machines have single doses of oral contrast material. And I've yacked to GE for many years about, even when Dan Peters was there. And I spoke to Dan a few weeks ago. Dan's been retired from GE for probably, I won't say a decade, but many years. And even those days, I said you need single dose, little pockets, cups, like when you're a little kid, those expand-style cups you can throw away. I think also people are a little bit uncomfortable, particularly nurses, on mixing contrast. We do it, our techs do it. We put a 100 cc bottle of Oral Omni 350 in a gallon of water, shake it, and we have 4 doses roughly. But you can't do that in the ER setting. If you're a nurse, you can't keep things around. They're unlabeled, and you can't give one thing to another patient. And then the nurse sometimes, what if we had a bottle, but then they would put the bottle in the wrong amount of water, or they give it too dilute or too concentrated. There's just the potential for error. And even though we know that if you drink oral contrast, the only thing is not, even if you drink it straight up, it's not going to harm you, right? It's just not going to be an issue. It might be too dense and be very annoying on the skin, but it's not going to hurt you any. But, we need to be very careful about anything that relates to prescriptions and drugs. And contrast is considered a drug now in most scenarios, surely from JACO and stuff like that. So I think this ideal would be a single packet. You get out of Pyxis, prescribe it, drop powder or liquid into a cup, go up to this level of water, give it to the patients, and life will be simple. So I don't know if that'll come along anytime. There was somewhere, someone's asking me a question, Vince, about 240 Omni compared to 350. We did all our work with 350, and I have really good feel for 350. For 350, every 10 cc's of use of contrast in a gallon of water gives you 20 Hounsfield units. So if you want more, so typically it ends up the bottle being about 210, 220 Hounsfield units. If I want to make it denser, I put less water, make it less dense, and get in more water. Siani made the point that perhaps with dual energy, that you want to have more dilute oral contrast material. It might create less artifact. It might be better. In that case, probably go to 240 will be well, because it has less iodine in place. And always remember, it's always important to shut off your phone before you talk. But that's my daughter, in case you wonder who I have Pretty Woman for. Nothing all that exciting. But I think, so maybe 240 might be good in that scenario. We have not done it. We can dilute down. And again, as I mentioned, with dual energy, it may be helpful. I think the big thing to me is when I give patients oral contrast, usually I find that if the liquid in the glass is about 200 to 220 Hounsfield units, when it gets into the patient and a little bit gets absorbed, it's more in the 250 to 270 Hounsfield unit range, which is really good. Nice opacification, no beam hardening artifact. With Oral Omni, the contrast is very smooth. There's no flocculation. Ben Yi was making the point that with barium-based products, you get flocculation, so that's not good. Creates pseudo lesions or hides lesions. So indeed, that works very nicely. Okay, any other questions? Sir, any Dropbox of your lecture? No. But all of our lectures, this is not a lecture, this is Facebook Live. You can watch it over and over for now to eternity. But our lectures, CTisus has a lecture every week. Those lectures are on the Apple Store. You can subscribe to the Apple Store, and they'll mail you the lecture every week. You can go to the website and download it yourself, or you can go to YouTube. YouTube has all of our lectures. Again, you can subscribe. We have maybe 15,000 plus people who've subscribed on YouTube, probably many, many times that on the Apple Store, which is where we started. But YouTube does have it. But this lecture, again, sort of more spontaneous, Facebook Live. There's nothing to put on Dropbox. Are you using plain water for the last drink, stomach at time of exam? No. I mean, if we're giving positive contrast, everything we're giving is positive contrast. We don't worry about giving water at the last cup. We give positive all the way. Obviously, if we're using water, and we'll use water all the way. I think mixing the two really does not have any advantage, and then also dilutes things in a manner that you're not really sure of. So I don't like things that I'm not positive of, and when you use the positive contrast with the right solution, it's not going to be an issue. Okay, let me see. Oh, it was 15:16. So we're sort of out of time. If anyone has a last question, this is your last chance to ask a last question. I'm looking. What about in regards to the bariatric patient? Bariatric patient post-op, I think you might want to make the contrast a little denser. We use the positive contrast. Again, the biggest issue, bariatric patients, the patients are so large. Omni is a good positive contrast. Omni 320, maybe you make it a little bit denser, so this, because of all the beam hardening artifact, but you're not going to have an issue with poor studies in that regard. And if there is a leak at post-bariatric surgery, you will indeed see it. So that looks like we're out of time. I say hi, Bridget, who says thanks to us. And with that, we'll see you next week at noontime. Bye.